Or-
Yes,
Yes,
we do. Yes, we do. Let me get some. Okay. Hi, Dr. Brown.
SDHIVC.
Right.
You're looking for parking, right?
C is just C.
Sorry, Jack. We're switching presenters, so just give us a couple of minutes while we get situated here, Jack. Thank you.
You're getting.
Yeah, 10 patients will take the folic acid and calcium.
Okay.
If they get COVID, just see what happens, basically. Yeah, all right. Where's Wilson? Oh. Okay, this one.
Can you guys please? We've made this a long meeting, but it's a lot of information here. Our next topic is very progressive because Owen Clinic has hired a doctor named Dr. Roger Kapal.
You said that really nicely.
Oh, yes. Who is the latest member, you're the latest member, aren't you?
For 5 years.
Well, 5 years, but you know, most of them are 20 years.
Yeah, that's probably true.
I've been
Yeah.
a patient for 26 years.
Are
or
you
something like
there?
that. Yes.
Are you at the office?
Yes, I
Oh,
am.
wow. Who's yours?
Dr. Lee's my doctor.
Oh, my God.
Dr. Caperna was my doctor before. He says I'm the
Wow.
best, Dr. Caperna says, I'm the best backup doctor to Owen Clinic.
Yeah.
Anyway, he has helped me so much. Dr. Caperna has saved my life,
Yeah.
basically.
Me too.
Literally
Wow.
saved,
Yeah.
I mean, literally saved
Yeah.
my belief, okay? Numerous times,
Wow.
and maybe soon once again, because my T cells are dropping like crazy and I have diabetes that's going out of control. On that note, methamphetamine is the ugly beast in the room. How many people know of somebody that uses meth? Almost everybody knows of somebody, at
Not
least,
me,
if
I don't know one person.
not one person.
No,
Well,
You're lucky.
I just pick and
I'm in-
choose wisely.
I'll tell you, you're probably,
Associate, that's what you should say.
I'm gonna tilt the camera.
Well,
in case you just said that Jeff is
Lori, I
You can
bet
see who's
you,
speaking.
I don't know, because the people that they don't have any of
I
those.
bet you're in the room with them. You're in the room with some of them.
Well, I don't know you, I only met you here today. Okay. but-
There you go. There you go, Lori. All right, order. Bill, Lori.
Yeah, I gotta go myself.
Okay, let's gonna go on. Dr. Rodriguez, gonna basically introduce us to what she is doing and what she is hoping to achieve at Owen Clinic. So, in regards to methamphetamine, I got an email from somebody in this meeting that said, you know, why are we talking so much about meth in the last 3 meetings? Because it's a drug, you know, and it affects us so pathetically that destroys our body, okay? I said last month that if you're using meth, you're killing yourself. And why is it important for us to be talking about it? Because I said, at the age that we're at, which is why we meet here, you don't have that play now, pay later capability anymore. You've probably exhausted, I have probably exhausted most of the immune system that I had in my younger years is gone. So my body is such that I really do have to subscribe to the Patti LaBelle, you know, temple routine, because there is no pay later. This is it. You use now, you're just basically pulling a limb off every time you use. And you could die in an instant. Not to mention the fentanyl that is within the methamphetamine of today. But it's not my talk, it's Dr. Roger Paul's talk. So please, without further ado.
First of all, I would have actually brought some slides next time I can.
Yes, yes.
Because I didn't know if I was going to be doing a presentation, but Dr. Caperna is so nice, and we met doing some community service recently in TJ actually. And then we both kind of were volunteering at a Las Memorias. I don't know if you guys, do you know what it is?
My friend was
there. So it's like it's a center for people with HIV, but also TB, and there's a lot of people with substance use disorder there as well. And there's just not treatment accessible for people, I would say, across the border, frankly, with substance use disorder, except for kind of imprisonment kind of treatments where people's rights go up the door and they don't really have a lot of like evidence-based stuff going on. But anyway, so that's where Dr. Caperna and I really just recently met. And then he said, hey, do you want to come here, help with us figuring out education or opportunities for treatment for methamphetamine use disorder? Of course, I said, yeah, because it's obviously such a big deal. Everyone knows that. Does anyone happen to know what's the major cause right now of death with fentanyl? Or sorry, I just said it. Fentanyl. It's actually fentanyl. And it's a little insane because, typically when you think of what causes death from methamphetamine, it's all the cardiovascular impact of it. Because it is a, stimulant, stresses the heart out, causes really high blood pressures, and causes strokes and heart attacks and damage to the blood vessels because of that. We know that. But right now in San Diego County, 50% of the death from meth is actually from fentanyl. And that's just due to unintentional overdoses because fentanyl is like 100 times more potent than what people are used to using on the street, including heroin. And that's been the case. It's gotten more and more prevalent since 2013 in the drug supply. So now it's in a lot of stimulants, cocaine and meth for sure. And if you don't have a tolerance to opioids, that's how you die from it. And I have actually lost a few patients, and this is before we were aware of fentanyl being, we didn't even test for fentanyl actually in urine drug screens until very recently, like a year and a half ago. So in terms of like harm reduction, first thing I'll say is if anyone is using meth that or yourself, is to test your meth for fentanyl. So there's actually fentanyl test strips that you can get now. That is so important, just to like keep the person alive. So I actually will offer it to people who I know, are currently using it, is to test their meth. And there's your like point of, so this is a test that you can basically either put in your urine or put in your stuff if it's like dissolved in water. And we actually store them now in our clinic, but you can get them even on Amazon. And the brand is called BTN. Have you heard of these before?
Yeah, so
Okay.
actually, if anybody's interested on fentanyl, prescription Narcan, our pharmacy gives them out for free, and if you see the tower of boxes, this is all Narcan.
I love it. Okay, good. Yeah, that's the first thing I want to say because that's the major cause of death right now with meth, increasingly so. So, and then the other thing that I'm going to say is, you guys have probably heard of this treatment called naltrexone, Vivitrol. Anybody else other than my patient? Do you know what it is?
No, what is it?
Okay, so yeah, what is it?
Naltrexone.
Yeah, naltrexone. So naltrexone. So okay, first of all, I just wanted to hi Sarah. Nice to meet you. My name is Amu. By the way, everyone calls me Amu. It's much easier than Roger Paul. And then now, so you can also meet my husband Evan, who works. He's actually a physician assistant who works in every day in a treatment center, rehab, actually residential treatment from acute detox to like follow up for like 30 days. So he's got a lot of perspective from that, like the continuity of that. But yeah, I was just telling the group that like the most important thing I want to say first is the fact that the major cause of death in San Diego County from stimulants right now, and particularly meth, is actually fentanyl, and which is unintentional. And the importance of like testing with fentanyl test strips here for fentanyl in your meth. The other thing I will say is the point of care test that we have, that you guys have here. It's really important to recognize that even if it's negative, that doesn't mean that fentanyl's not in there. And that sounds scary, but because obviously it depends on what the concentration of the substance is, right? And like, we don't know how pure it is, but just to trust it if it's positive, obviously. We can ask a question,
Sorry,
yeah.
There's a question on the
Yeah.
chat from Jack. What's the harm reduction strategy with fentanyl testing strips?
Mhm.
It's not like people are gonna throw out their death
Yeah.
on drugs, so they lower the dose.
That's what I got for you.
Oh, there, thanks, that's the one that I use in clinic.
Those are fentanyl testing strips?
Yeah.
I've never seen them.
Yeah, everyone should have them,
It's
who's
not
using.
right, it's
You can get them on Amazon now for pretty cheap.
Yeah,
They give me one.
Yeah.
I heard that at Owens Clinic,
Yeah.
they're having two, fentanyl deaths a week. Is that true or just?
Yes. Well, it's the emergency room.
I'm sure they do
has
there.
at
I'm sure they
least
do
that
Well,
every day.
but there are two a week.
I don't know if it's 2 a week,
I was not
honestly.
sick or
I
something.
haven't heard that. It wouldn't be from our clinic that it's 2 a week,
No,
because
no.
that would be, we would be
No,
talking
no.
about it. But I am not surprised if that's the case like in general. Yeah, I mean, yeah, it's more than that, probably, yeah.
Anyway,
yeah.
if you want a test strip, take one, at the end. And the reason why I have them here is because, as I often say, and you should get a Narcan, free Narcan too.
Yeah.
You never know who comes over to your house, who may be high,
Yeah.
and, or who maybe has meth, or uses meth that you know of, and you can give it to them to test their supply. You know, so it's a very addictive drug, very.
What are people saying in the streets? Like, how often is it turning positive? Are they getting surprised, like, oh my god?
I have a lot of
Like
people,
Jeff Taylor
yeah,
said, yeah.
Yes,
it's very prevalent.
very,
So-
when you least expect it.
We should look it up.
And then
actually,
what
the
do
drug
people
seizure
do, like Jeff
prevalence.
said? They just cut the dose, they don't trash the whole thing. Their whole.
Well,
Probably, so this is the next thing, so, okay, obviously it's helpful to like have some, like, at least doing the testing, obviously that's not FDA approved yet either, which we need, but this is something else that you probably haven't heard of, so I mentioned, naltrexone, so naltrexone is an oral opioid antagonist that's been available since like 1980s now, and, it was used for alcohol use disorder, for opioid use disorder. It's approved for those indications. It's I think about.
It's used for
Actually,
weight loss and contrary, I don't know.
Yeah, I was actually gonna let me take that back. So oral naltrexone is not actually available for opioid use disorder. Injectable form of it is approved for opioid use disorder by FDA. But oral naltrexone is certainly available for alcohol use disorder. But the way that it works is it's an opioid antagonist, and that might make zero sense to someone who's using meth. But this is the important thing to recognize, is that with a lot of different substances, there's really preserved pathways of reward, and the opioid pathway is a major one of those. So even if you're using something like meth, its reward is in part through an opioid receptor as well. And same thing with alcohol, and same thing with even gambling disorder. And there's evidence for, I'm trying to think of what other thing, binge eating, like food. So there's preserved reward pathways with different
dopamine?
substances.
Are you talking about?
Yes, that are linked to dopamine surges, right, in the brain. And opioid receptors are one pathway. They're not the whole pathway, obviously. So, naltrexone makes a lot of sense with opioid use, and with alcohol, it doesn't make such intuitive sense, but it has been shown to help. So stimulants also work through the opioid pathways. And there is evidence that, oral naltrexone helps. It's not strong. The studies have been really limited by people just taking it, because that's an oral medication. You have to take it every single day. Therefore, there's been studies on using long-acting naltrexone, which is Vivitrol, okay? Because that way that you take out the adherence issue with that, because now that you have something that lasts for a whole month. And so there is evidence, there's a few studies on that showing that people decrease their use of like meth when they get Vivitrol. Now I'm going to introduce to you something else that I've been doing more recently that I think is actually really, really important to think about. I'm offering every single patient who's, even if they're not interested in cutting down with meth, being on Vivitrol again, which is this opioid antagonist that lasts a whole month, because it blocks fentanyl. So even if a person, is using meth, at least they don't have to worry about dying from it. And like just from the major cause of death right now. So like I'm actually recommending it, even if someone's not interested in cessation of meth. And I've had patients that have had repeatedly positive fentanyl drug screens and they're not overdosing anymore. And these are people who had been in an emergency room. So like that's an important reason to ask your physician, to about naltrexone or Vivitrol would be better because you don't have to worry about the adherence with it.
So what,
Yeah.
so two things. So fentanyl is basically a lot of stuff.
Mhm.
So as a drug cartel, I'm thinking,
Mhm.
why would I inject or put fentanyl in a product that I know that might cause people, because that would take away from my money,
Yeah.
right? And then the other day I met this guy and we were talking and he's like, the first time I met him and he goes, me and my friends, got scored some meth and then we put it in a testing kit and it came up positive.
Mhm.
And then he told me, he goes, we did it.
Mhm.
And I just like, it's crazy, right? I was like, dude. And then he looked at me and he goes, well, what were we gonna do, throw it away? Like, we went through the whole process of scoring it,
Right.
and, to me, I was like, it just couldn't comprehend, but, he's like, we're here.
Yeah, I know. I think I know there's gonna be papers published on like what's the effect of people testing their stuff. Like how does it influence their behavior? Even if it's a pause, right? I mean, if somebody's interested in getting the strips, then that means that they're interested in that information. So I will always give it to people who are interested. And most people are actually interested who are actively using when I tell them that they can get at least try using a fentanyl test strip. But I would say almost everyone's interested in getting a shot that blocks fentanyl.
And
That's
you-
not their drug of choice.
And you think fentanyl is here to stay?
Do I think what?
Do you think adding fentanyl to methamphetamine is here to stay?
Well, it is here. I mean, it's here and it's causing most of the death from from methanol. So it's not even it's not a question. It's here. So I don't know why they're doing it, obviously, but yeah, I think that's a question a lot of people have.
That was
But
my question, is fentanyl
Yeah.
itself addictive?
oh my God,
Oh,
yeah.
God, yeah.
So that's why
Yes,
they're adding
yeah,
it.
that would be a good reason.
they're adding
So
it,
if you
it's
survive,
addictive.
So I certainly have patients who are using fentanyl now that weren't, that wasn't their drug of choice, that now it's become something that
Do people use fentanyl
Just fentanyl.
just like
Yeah.
meth, like people use meth
Yes.
for la la la.
Yes.
Yeah.
So they use fentanyl just
For
for
recreation? Oh, yeah, so initially, yes, I would say that, what's been really interesting to me, in treating substance use disorders is that, I would see people who are interested in getting treatment when they were injecting heroin or, using other opioids, but with the higher potency, like more powerful stuff like fentanyl, people are more desperate actually to get help because it is the leading cause of death right now under age 50 in the whole country and in San Diego County, in a lot of counties. So, and people are a lot more desperate because of that situation of, knowing people who died and overdosing themselves. And the fact that fentanyl is more, creates more, it's more addictive. So they're having to use it more frequently throughout the day. It's really expensive for some people, depending on where you're getting it from. But I've had patients who are homeless, are shelling out somehow thousands of dollars on that a week. And that's the reason for wanting to, kick it.
Question from Palm Springs is, Jeff, what are you trying to say with sex addiction?
Oh, that's when she was talking about using naltrexone to curb various addictions and mentioned gambling and others.
Yeah.
Is sexual compulsion one of those that it helps with?
There has been studies on that too. There's very limited evidence on it. It's not like a recommended first line treatment for that. Actually, for sex addiction, it's, believe it or not, it's I'm trying to think of the word SSRIs. How do you, it's basically antidepressants. And the reason for that is because they have bad sexual side effects that make you not as interested. So it's that bad side effect that people don't want to be on Prozac is actually why that's recommended for sex addiction. Yeah.
Wow.
So this group wants to find ways.
Yeah.
To help people use less meth,
Yeah.
reduction.
Yeah. Stay alive first, right?
Yeah.
Yeah.
And to recognize there's different parts of the when people stop, there's a 1 month physiologic withdrawal.
Yeah, at
And then
least.
there's like, non-physiologic
Yeah.
health for 6 to 12 months.
Yeah. So we, I mean,
What to do,
yeah.
and we don't believe as a group that injectable naltrexone
Mhm.
works in that many people. I mean, the best
Mhm.
published is the New England Journal article that I know is
So,
14%, right? And they followed
Yeah.
for 6 months.
yeah, so
Is
the,
there more evidence?
I mean, I had to dissect that trial a lot because I presented on it like so many times, including at our public health department. But I would say, so there's 2 studies that have been done on using long-acting naltrexone, which is Vivitrol again, in combination with a stimulant, which is Wellbutrin. Just to explain again why they looked at this, it's because like Dr. Caperna is talking about, we know that there's this we know that meth is phenomenal, increasing people's dopamine levels in so many different mechanisms in the brain. So it's no surprise that it's a drug that people would enjoy doing at some point, right? It's like way longer acting than cocaine and other stimulants in the body. Its effects last for a couple of days. So it's a great antidepressant and has lots of other wonderful benefits. But then the problem with that is our brains shut down doing that naturally too. And so we know that there's this, terrible side effect that you can actually see in the brain in terms of the dopamine production and binding that is impacted longer term when somebody stops using meth. And that can take a long time to recover. And some people, if they've used it for a long time, it may not recover. Meth can actually kill the neurons as well. So anyway, the point is that so what do we do? So you give somebody something like Vivitrol, what does that do? It blocks reward. So that's even, it's like that person's not going to be happy, right? They're not using meth maybe as much, perhaps. And then now you're giving them something that blocks one of the reward pathways in life. That's, we need for other things too.
Which it
Eating food, right? Enjoying food too.
blocks
Yeah.
it, blocks it at what point?
yeah.
They don't ejaculate or they aren't excited about something?
It's just literally not getting as much of a dopamine response because the opioid pathway is blocked now. There's different ways that you're getting reward from all of these, things that we enjoy. So
What did
one
you
of them
see
is
in the
opioid.
Owen clinic in terms of side effects?
Mhm.
I've used it with only 3
Yeah.
patients in my small private practice,
Oh,
and it worked remarkably in one guy.
okay.
He
So
said he just felt like pumped and low.
Yeah.
and
so
he didn't want to do it anymore. So
I've seen lots of different.
it's like this
responses.
low energy punk feeling.
I've seen a lot of different responses, and yes, that's not uncommon for people to say that. But that's why in the 2 studies that these really rigorous studies, the reason that they combined the Vivitrol with Wellbutrin, because Wellbutrin increases dopamine levels. That's how it works as an antidepressant. So they combined it with a stimulant to kind of improve some of that low and help people get out of bed. Yeah. Yes.
So one of the things we discussed as a group
Yeah.
is that, maybe we can do it after 12:30.
Yeah.
After the end.
Yeah.
There's a completely irrational way the medical profession
Yeah.
is looking at treatments for methamphetamine.
You mean repurposing drugs?
I'm
Or what?
talking about where are the clinical trials? I'm
Mhm.
talking about where are the trials of pharmaceuticals to
Mhm.
help people as they are trying to detox.
Mhm.
And frankly, I've got a declaration to make to you guys. I've done some research and I've been talking to people. And I've given up.
This is
on
Dr. Brown
the
speaking.
community.
Mhm.
And the people I'm going to are cardiology
Mhm.
and pulmonary. Because these are the people that are dealing with the guys who come into the ER and die, and they give a shit, and they don't have these massive hierarchies of money being spent on this and that.
So let's
people-
collaborate with the cardiologist.
And the pulmonologist. I'm done. I
That's for
did that.
you home.
I'm
IT,
no, but
pulmonary.
I realized from my discussions that this is the way to go.
Huh.
Because these guys have had it
All right.
and they want
Well,
something.
we need a PI.
Yeah, we need,
We're
yeah,
kinda
but
like
I'm just saying
semi-retired.
that's, we're old farts. No, we're old farts, and it's not our area.
I wouldn't call it
What
that.
we wanna do is like, we're medically trained,
Yeah.
so that's the way our brains work.
Yeah.
And when we look at what's going on in the medical community,
Mhm.
as far as we've been in this for 30 years,
Mhm.
this is not rational. This is not rational.
Well, I will say so I got addiction medicine certified too, board certified in that, aside from infectious diseases, but it came out of my interest from hearing about the issues from patients and recognizing that we're not helping the number one cause of people both acquiring HIV right now and also not taking their medications and, getting all sorts of complications from AIDS, but also methamphetamine long term. in the community. So my came out of a genuine interest learning more and more about it. But I will say that there's what I've learned is that we don't learn anything about substance use disorder during medical training. Okay, so like most doctors are frankly ignorant about it, and that's not just their fault. It's the system itself doesn't really educate people about substance use disorders. It's highly stigmatized, and kind of personally, people are almost basically patients or people are responsible for their bad decisions. Is kind of like how the there's a lot of stigma and this kind of philosophy, like, and it's ignorant because everyone knows somebody who has a substance use disorder. It's incredibly prevalent. It's like almost 1/5 of the US has a substance use disorder, right? At some point.
In your,
So,
in your
yeah.
practice.
Yeah.
Are you finding, well, if you were to guess, I don't know
Yeah.
if you, I don't know if you track it, but
Mhm.
what percentage
Mhm.
of your patients
Yeah.
are this
Benefiting?
age, are this age?
Mhm.
Or what is the predominance of your,
Yeah.
of the people
People who are using
using meth? At what age?
Mostly young adults. Mostly young adults. Yeah, right now.
So the
It's
older.
common everywhere, but yeah.
The older patients are ex-users or, dead.
I don't think they're telling them.
There's even more
That's why
stigma in the
maybe
older
they just need to
generation.
Do urine tox screens and everybody, because I had one patient, he came
Yeah.
positive for coke, and I go, why didn't you just tell me? I just did it because I'm supposed to do it, you know.
don't tell.
Because I couldn't, he said, I needed the testing. And then other people don't want us to do the testing, but how do we need to know this information, right? And I think there's a lot of older guys that just aren't saying, and we don't know because the only way to know is if we did a urine tox screen. Remember the
We,
discussion of
and
that?
I do new digital technologies,
Mhm.
and I ran clinical trials
Mhm.
in prep,
Mhm.
in treatment, and then hospitalized.
Mhm.
And within 2 weeks,
Mhm.
because I used to help them at their own clinic, like go in to do animal care and
Yeah.
stuff, we never overlapped.
Well, I only joined there 5 years ago.
Yeah, I was
So-
out of the mix, I think, maybe
Yeah.
just about the time you were.
Yeah.
born. So what I was struck by was the massive difference between what I learned in 2 weeks in clinical trial than what was going on in the clinic. It was like,
Well, they don't address it. They just don't address it.
well,
Yeah.
they would, yeah, I guess that's true. That's exactly true. We were asking people to fill out a
Surveys.
substance use questionnaire.
Yeah.
And we then, after 2 weeks, I was saying to them, I'm a North County housewife. And the woman who was running my study was another North County housewife
Mhm.
who went to Roman Catholic convent schools, for God's sake, for high school. And if the two of us can work out this is a big effing problem within
Yeah.
2 weeks, what
Yeah.
the hell's going
Well, what
on?
you did is
Like, it starts-
she just did urine
Yeah.
toxes on everybody
No,
in the
but then when
study.
they came in and
Yeah.
told me
And
what
was
was going on,
surprised.
I said, this is weirdness.
Mhm.
You're gonna tox screen everybody when they come
Yeah.
through the door. You tox, because A, we can afford it, and B, we don't know what's going on, and we're not gonna pick certain people out.
Mhm.
We're just gonna do tox screen on everyone.
Mhm.
And then when we did that, the signal came out that PrEP, the use was, I think it was something in the maybe approaching 20%. In treatment group, the signal approached, it was about 45%, and in the hospitalized patients, the signal was over 60%.
And the patient said, I am using?
No, they.
Or it was never asked
Okay.
clinically, it just wasn't addressed. Yeah.
Like,
Most,
anyway,
yeah, it's not addressed. We know that. Like, I actually teach at the medical school at UCSD, and I went there as a medical student, and it's funny because what I did was we did a needs assessment recently, which is just to see how many of the medical students from first year to fourth year are comfortable seeing a patient with substance use disorder, just so we can start to make changes in the curriculum. And the funny part was the interest level is so freaking high for actually learning about substance use disorders and wanting to help this population, which is everybody, by the way.
Yeah.
I really believe that.
Right.
But the funny part is they feel extremely
Yeah.
uncomfortable
Yeah.
actually helping this patient population, even though they're interested, and that the interest level actually goes down as they go through medical school. And I think it's because they feel like they can't do anything because they don't see any role models who are actually treating substance use disorders successfully. And I mean, it's a system issue that is going to be very slow to change. We just need, fortunately, there's now this addiction medicine board certification, which is very recent actually, and there's going to be more. I see so much interest in the medical students and the residents to like learn more and actually like do that kind of education for themselves. And it came out of desperation for me. I
Is
think
Narcan,
they're gonna-
Narcan,
yeah.
is Narcan work on meth?
Narcan is a short-acting opioid antagonist that
Mhm.
basically blocks you from overdose if you have like unintentional, opioid in
Right.
your meth or any other substance. I am gonna disagree with you guys about something though, because you had a large panel, I'm sure, Dr. Caperna, but I have 250 patients in my clinic currently, and I will say we know that the prevalence in people with HIV for substance use disorder is like 50%. So I have a lot of patients with substance use disorder. I will say that most people shockingly have had a benefit with Vivitrol. I have been surprised, really honestly surprised by that. Because like what you talked about with the study.
I'm just going published
Yeah.
versus.
Yeah, you're going published. So this is where this is important. So again, I talked to you about the fact that people are dying from fentanyl in it. So that's one good reason to do it. But then the other thing that shocked me is, so in the study, they actually had pretty good adherence. So they were able to see like what is the effect of people getting this drug, Vivitrol. The thing that they didn't look at, so what matters is like what was the result they were actually measuring. They were looking at whether or not the person had a positive or negative urine drug screen, but that doesn't tell you if somebody decreased consumption, because the test is still going to be positive even if they have small amount or a large amount of meth in them. And so what I've seen in clinic, and like this blew my mind and it blew some of the other physician who's also helping with this, is that people start showing up to their visits and their HIV viral load is going down. And that's because they're taking their medication. So even if they're not, like they maybe have using every day before, now if they're using like once a week or using once a month, like that's making a huge impact still, like on their, on their functioning and their ability to take their meds. So that is worth to me to like, obviously offer what we have. And I've been surprised, and we all know that like we have genetic differences. And like this is true with alcohol use disorder as well. Whether or not somebody responds to naltrexone or Vivitrol depends very heavily like on their opioid, on the target of the drug. And so some people don't have any response, and then there's some people who have a great response. And so, and that's seen with alcohol use disorder as well. Like I have patients who've gotten on Vivitrol and stopped drinking, actually who drank for like 40 years.
If that's the case,
Yeah.
is it possible that it might not work to
Yes.
save somebody's life?
Yes. No, so,
They don't
oh, I
have
see what you're
to
saying.
stop
Well, I mean, that's a good question. So it does block the opioid receptor. It may not help them with, we don't know how much it'll help them potentially with meth. It certainly blocks the opioid receptor though. So that should block at least
I'm talking
overdose
about-
from an opioid.
Okay.
Yeah.
Okay.
But I'm talking about like whether or not it helps with like cravings and reinforcement with like a stimulant or something else. So I actually do have patients. I actually was in clinic yesterday and I had a patient who literally stopped using meth after getting Vivitrol. He's not the only one. I have because of having such a large sample of patients, I can say that there are at least some people.
I just haven't.
Yeah,
I tried
yeah.
3 times.
I will say that's the minority.
One time it worked great,
Yeah.
and the other 2,
Yeah.
they just didn't follow up.
Yeah,
They got like 2
They have to
shots
show up
and they
too.
just stopped. Yeah.
they have to show up too. So
Yeah,
adherence limits it too. So
Well, what about,
Yeah.
you say it's once a month?
yes.
Maybe some of them have no cravings for a week or 2 weeks.
So that is huge. I'm so glad you brought this up because something else, there's so many variables, right, that need to be studied. Like this is fairly new information. We only had for like the last 2 years. I mean, using these drugs for meth. But like we know that like Vivitrol and naltrexone gets metabolized differently in everyone. So the clearance rate is different. So
Mhm.
some people are going to need to get it every 2 weeks or every 1 week maybe, or every 3 weeks. And like, just depending on how fast they clear the drug.
Mhm.
And like we already know that the drug declines differently in people. So like that needs to be looked at. And, insurance plays a huge role because they approve the frequency of prescription too. Like you can't get it for somebody, if they tell you their cravings are, improved for 1 week, you can't get it for them every week.
So
Because that's not how it's allowed.
to
Yeah.
push this conversation forward about should we study something? Are you satisfied with
No. So this is,
Vivitrol, or should we
Yeah.
study the thing? And what should we study?
So,
Is it
yeah.
addiction specialists?
So one good thing that is happening is a lot of doctors who are seeing addiction mainly noticed that this is happening. So there is a multi-center, I think it's like 14 sites. There's a multi-center large population study that is going on starting in June. So like literally it's what today? But literally starting this month. And UCSD is one of the sites.
Uh-huh.
And it's just to look at in a larger sample of people the effects of Vivitrol with Wellbutrin. I think a limitation again is if we just look at positive urine drug screens, we need to look at other measures like people showing up at their visits and like there are other health outcomes as a result of getting the medication. We won't capture all the effects of it otherwise, yeah.
Who's running the trial?
Who's running the trial? It's the National Institute of Drug Abuse.
Okay,
Yeah.
and then
Who's doing it locally though?
Locally, I am one of the study physicians, but I'm also not, I may not be able to continue doing that work for a reason, which is, I haven't even talked to my own patients about.
I heard.
You did?
you know, the-
Oh, God, help me.
It's okay.
Yeah, it's so sad. I mean, like.
She's 12 minutes ago, she's leaving.
But is it like?
Yeah. Huh?
Yeah, go to
Nida.
NIDA, yeah. Oh, yeah, who's reading it? Yeah. Yeah, so the principal investigator at UCSD is addiction psychiatry. So it's Dr. Antonelli, who's at the VA. I don't know if you know him. I just met him through this, because he was asking for more, yeah, people. So it's all addiction people, though. There's nobody who's not an addiction physician who's gonna be running the study. at UCSD.
that's good.
That's a good thing.
I mean, we're
Yeah.
so grateful for you and we're so proud of you. Honestly, as a physician, I'm grateful and I'm proud of you because we were not sitting here to say, to criticize you. It's that what because we've discussed this, as a group here, and the only conclusion I can come up with is that, when docs are trained to try and save people or try and make a benefit and they just don't have any equipment with which to do that,
Yeah.
it's gonna be hard for them to move towards that goal.
We're failing. Our healthcare system is completely failing the substance use disorder situation.
But
Like, that's fact,
you know,
yeah.
you're not, you stepped into the breach where there isn't a lot, and we're deeply.
I don't have
grateful for
kids
that.
yet, and I had time to go do another board certification.
I have
Like, that is the reason. It's like, we're like both like just interested, and he has family that's like died from overdoses, so it's like, interest, yeah, important.
It's coming up, so
Yeah.
old farts at the back.
Yeah,
What we're gonna try and do is give a bit of support. Try and identify, we understand how the system works, and the system is not pretty.
no, it's
The
terrible.
system of research is not pretty, the
Yeah.
system of care funding is not pretty, the system of care.
The system
is
of maintenance of sobriety.
It's not pretty,
Yeah.
right? But on the other hand, we know that.
Yeah,
So what we're gonna try and do with the whole group, one of the suggestions last week, or the last time I came, from somebody was actually, I thought was very clever. There was a guy here who said his next door neighbor is some heiress from the body shop.
Yeah.
He said that we should consider putting together a privately funded initiative. And I
Yes,
think
yeah.
that might be a good idea, and I'll tell you why I
The
think it's a
makeup
good
people,
idea.
there's money at MAC. and stuff,
Because
yeah.
I heard, I've been doing some research.
yeah.
Just informal chatting
Mhm.
with people who've been, I spoke to this one guy who I said to him, why isn't this happening, why isn't that happening, why isn't the other happening?
Yeah.
And he said to me, welcome to my world, welcome to the last 20 years
Yeah.
for me.
Yeah,
So it seems that there is some prejudice at the very top.
oh, yeah, there's a lack of prioritization too,
There's
just, yeah,
prejudice at the very top,
Yeah.
and there's also this, what you're talking about, the social
ignorance,
thing.
yeah.
Biden has a methamphetamine task force.
San Diego County does it, no one knows about
Is
it.
to get naltrexone,
Yeah,
Vivitrol available,
yeah,
when I really read about it.
Yeah.
But anyway, there's something going on specifically, Biden,
yeah,
Yeah,
That's
there
a task
is
force,
going on, but
specifically for men.
I think
Yeah.
that if we, we're gonna look around, I've talked to one guy who's been doing this for 25 years or longer. I now understand that we could get some pressure from the cardiologists and the pulmonologists. And the reason I'm interested in cardiology and pulmonology is they have much more money than infectious disease.
yes, right.
Because
They
truthfully,
do.
NIDA and HIV people have let us down.
Mhm.
Sorry,
Yeah.
but they let us down. If this is this big a signal
Mhm.
and we don't have
Mhm.
and I have been in ACTG meetings
Mhm.
where very senior, very connected people have said, guys, there's an epidemic here, young people are dying, we've got to do something.
Yeah.
And then the very next statement is by somebody who's trying to preserve their own research.
Yeah,
but I really
Yeah.
wanna work with the OM clinic, we like have.
Well,
that's where
well,
so,
yeah,
I mean,
but
it's
Family
such a
Health
large
has the other
circle.
huge chunk of.
Yeah.
people
do,
in the
but
county.
I'm
Yeah.
telling you, you go to the ER.
No,
It's such an
not
ER,
until you.
yeah.
I don't know what
Yeah.
I'm gonna do now.
Well, so, okay, so this is what I can, this is what we tell you, okay, go ahead first.
One thing that with, Dr. Brown did it,
Yeah.
one time, the first time I met you, said, the face of addiction need to be included.
Yeah.
We need to, because we are the ones who said, we know how, what we've gone through, what we know who's dying, our friends who are dying because of field using and we're not.
Yeah.
We, the face of addiction, need to be present
Yeah.
too. Because
Yeah.
you said it one time, said, we are the ones who got the money for HIV. We demanded it.
You
Now
did.
we need to demand that money and that care for
But
addiction.
Jamie, what you need to work with us.
Yes, definitely.
Who do you hit and how do you hit?
Yes.
Because the thing that I'm looking at is when I'm talking to people, so I am not a big power person, but I have been in their structure and I've seen how they work and I've been watching
Yes.
what's going on. And my instinct is that one of the things, use no offense.
Yeah.
Please, whatever, and I don't care. One of the things you see is this big.
No, I have a lot to say
they
about
have
UCC.
come to a community meeting, and then they tell you what health equity research is.
Don't
I
get me
wanna
started
bang
on
my
that.
head against
Yeah.
the wall.
Yeah.
I'm like,
Well,
Yeah, no,
"Oh
okay.
my
You
God."
see, we said, we want to say, we want to volunteer
Yeah.
to talk to patients,
Yeah.
talk to patients,
Yeah.
pass out fentanyl tests.
Yeah.
And said, we're
Really?
sorry, liability.
Liability, yeah.
Okay, so.
So what are you doing that through what group?
You're
We just
helping
decided
out.
we
Just
need to-
because you two are doing it.
we need to help. We are so grateful that,
Okay.
Dr. Escobar,
Yes,
Sarah Lodge.
she's a hero.
Yes, anyway, so. We want to pay it forward. And
You
then
guys are heroes.
allowing us
Yeah.
to.
Yeah.
Well,
I think we should work together.
yeah, I'm
We need to
happy,
work
I'm
together.
really happy to work together. So the other thing I did, I had a great rapport with a guy at UCLA who's been doing this for more than 2 decades, and he's the one that said, welcome to my last 10 years.
Yeah.
So I think, we can, and I'm just saying that like I said, I'm a housewife in North County and I have children and I'm absolutely appalled at what's going on in this society.
So one, yeah.
If you think about what happened back when,
Yes.
in the early days of the
Yeah,
AIDS epidemic.
yeah.
When, ACT UP and other groups.
Yeah.
TAG, others.
Yeah.
Really got things moving.
Yeah.
And changed the course of
Yeah.
research, created early access programs, all the things that happened.
Yes.
It wasn't because we interacted with the medical community.
No.
It's because
Yeah.
we got Elizabeth Taylor to get out there
Right.
and talk to
Right.
Nancy
Right.
and get shit done.
Right. You need
So an
advocates.
advocate that is
Yeah.
not part of
Right.
the community.
Sure.
But can loosen the purse strings from the top down.
So I completely agree. I will say that, so the reason, I mean, just so John, so you know too, I'm sure I've talked to you about this, but like the reason that just to give you like a clear example of how the healthcare system is not helping, the reason that I was frankly recruited to go to UCSF to help there is because in San Francisco, there is at least a lot of investment from the healthcare professionals in this cause, which is like really, it's relieving for me. Because what I found is that even though I can like offer all of the options that are available, with the new stimulant use disorder guidelines for people in my clinic at the Owen Clinic, regardless of, because even with Medi-Cal, right, or Medicaid, we can't help anybody who's going through the emergency room because none of those patients are actually allowed to go to a UCSD health clinic because of their insurance. So the vast majority of people who are actually using drugs don't have insurance that's compatible with like an outpatient addiction clinic. And it's hard to get them into treatment, period, actually, in San Diego County where they offer treatment. So like that is the limitation. It's like these insurance restrictions that like the healthcare system has created and prevents the people who need it the most from getting help. And I hope that will loosen here, but like I basically said, like we can't exclude the people we're taking care of in our hospital, like, cause that's where I also work too. And that was like very unswallowable for me. So, but like in UCSF, just so you know, like what is happening in the country, right? Like just like they made access for ART for HIV available faster than any other part of the country. And there's few cities in the country that tried, right? The clinic that I will be working at there is a walk-in clinic for people who use drugs nobody gets turned away if they wanna come in, it's every single day. And they're trying to create 24/7 services for that too, like street medicine teams there. So like that initiative from the leadership was the reason for me, you know, being interested in this to go there. But it's so sad because here, clearly, it's going to be even more underserved if people who are interested to leave. But it's because like we need to create a model though too, like for other systems, and that doesn't happen here easily.
So why did people lose interest in going through medical school? Why did they lose interest in trying to treat them?
Because they don't see success, because no one is actually
Oh.
treating anyone. Like
Oh.
90% of people don't get treatment who have
But
substance
but
use
you
disorders.
see successes.
I've seen a lot of success, and it's actually what changed me and what made me. The reason I even decided to pursue the addiction medicine
Wow.
certification is because I was seeing impact when I was actually helping people, not just with meth, but like with like other addiction, like opioid addiction for
Do
sure.
you see psychological issues with meth users? Do you find
Oh, God.
psychological?
Chronic ones, yeah. After
Well,
that, sure.
Yeah.
Yeah, so it affects certain parts of the brain that are unfortunately can be long term.
This is
Yeah.
anecdotal, but I have a friend who had, unfortunately, she doesn't do meth,
Yeah.
but she has somebody who lives in her house.
Mhm.
And I talked to, I'm from Southern Oregon, and you're gonna think I'm a little bit weird about this, but I talked to these people who were these Christians, and they were telling me that meth use itself chums in negative energy, like negative spiritual energy. And I go, wow, that makes sense. That's
Sure, I mean, why not?
No, it doesn't. It just takes someone's soul away.
Yeah.
There is no spirit.
But
Yeah.
What's going on?
Yeah.
We gotta wrap up though.
Yeah.
Yeah, I agree. Yeah, go ahead. And then, yeah.
Okay, this
I think it's time that we all start getting involved, and because of Dr. Caperna, Dr. Brown, and Dr. Rodriguez,
Yeah.
I've decided to get back into politics, and I'm gonna run for Congress in 2026.
Okay, so one thing that I can say though, I mean, I'm gonna hear your question. I was just gonna say that this NIDA trial, even though it's National Institute of Drug Abuse, when like I will at least give you, or you know, whoever's here is in admin, the information so that if anybody you know is interested in at least being enrolled in it, they'll get paid to be in the study too, like $1,600 for being in it. And they'll get transportation to it and everything, but that way they can get treatment even if they don't have a doctor or they don't have like insurance coverage of the medications.
Yeah, so that could be part of our,
Yeah.
like our follow-up email that we have.
Correct.
That's something important that came to.
By the way,
Anyone who's eligible, like person who has actually, they have to be using more than half days in a month. They have to have pretty. They're gonna see them in a clinic in La Jolla, of course, but they're gonna transport the patients there.
Oh, they are?
Yes.
by the way, Jeff, you want to ask your last question?
And then-
Oh, yeah, I was just fascinated about the trial, and I'm sure it's a nationwide trial, I assume.
It is, yeah.
And I'm in
But
Palm Springs. We have a
definitely
huge problem with meth here among older, especially gay men, a lot of them with HIV.
all of them
So I'd
should,
love to learn more about the trial and see if we can get somebody interested here in becoming a study.
anyone who wants treatment should get in it, yeah.
So yeah, is there a clinicaltrials.gov link or a link to the study itself?
Yes, there's absolutely, so I'm gonna have like the information to,
Post.
for recruitment that I
Yeah.
can give you guys, yeah.
Oh, perfect.
I'll
Thank you.
Send it out on the.
That will be helpful, yeah, anybody who wants from
Thank
here can come.
I like-
One specific useful
Yes,
thing.
yes, yes, exactly.
I like the way Jeff calls the Palm Springs the waiting room for older men seeking men.
Yeah, sure,
Right,
And
one more question, John, and then.
go ahead.
people
This is
can-
anecdotally speaking.
yeah.
I actually was prescribed a lot of medications. One doctor was surprised about so much, and I was physically addicted to it. However, apparently there's something about it because I kept going. I went into withdrawal a couple of times because
What medication is it? Just
I
curious.
was on morphine, Percocet.
There you go.
A whole bunch.
Yeah,
A whole bunch.
yeah,
of
there you go.
And the doctor was surprised that I was driving because
Yeah.
I said I have insomnia.
Yeah,
But I found out that
Yeah.
I don't understand because the reason I was going to
Yeah.
withdrawal was
Yeah.
because, I mean, what do you call it?
withdrawal.
Okay, withdrawal was because I never felt any side effects from the thing. For me, it's just another pill. And so, and the same thing, when they still do it now, I discover I have to take twice the amount, but I don't.
Exactly, because it creates tolerance, yeah.
Well, no, I have never felt
Yeah.
any good. People
Right.
sit there and ask me because I had
Yeah.
so much left over because But I said, I don't see why people sit there and take it, because for me, it's just another pill. If it weren't for the withdrawal, I wouldn't even do it. And then literally, I asked the clinic how long it takes to get off of this thing, and they gave me a time scale. That was much too thing, and I finally talked to my pharmacist, and he actually gave me an accelerated thing, and I went on the accelerated diet, and that actually did work. But I don't understand this. I don't understand this, the reason people take this stuff, because I've never felt good or anything. It's just another pill.
Everybody's different.
Unless I was in pain.
Everybody's different.
I was only taking it because for pain, but
Yeah.
once the pain is gone, there's no need to. But I discovered.
And is
Except
there a
and is that
titration?
something
With
that
the opioids?
people,
With opioids?
people actually feel a
Oh, with
good
meth.
thing of taking this
I always
stuff? I
heard
don't-
soup in the
Oh,
sandwich.
yeah.
I mean, sleep in the sandwich. That's all they offer me.
Yeah.
I've had people tell me it's their best friend. It's the only thing that gives them
What-
joy. Fentanyl.
Oh, sure, yeah.
You know? Yeah, you can
Yeah,
certainly,
lots of people.
you can certainly feel, massive euphoria with it.
Yeah.
I've never felt any good side effects from it. It's just a pill.
The fentanyl
Yeah.
epidemic came up today, that's number 2 important. I
Yes.
didn't know the strips were even
Yeah.
available so
Yeah.
easily. We should put that,
I-
really important things.
I think asking your provider or your clinician, even if they don't know, to look it up for like getting Vivitrol just to block a unintentional overdose for you is important.
Yeah.
Because I actually have patients, like I said, that have fentanyl regularly now in their meth, okay? But they haven't ended up in the emergency room again. And the reason I saw them was because they overdosed. So they were in the hospital for that, and then they just needed to be on something to at least block that. Even if they don't want to cut down meth, like for that
Another
reason.
thing that Dr. Raja,
Yeah.
I just burned.
Call me on,
my
please. My God. Anymore.
Thank you. Is that in November 2023, the addiction guidelines added, you can use a stimulant for
Yes.
methamphetamine
Yes.
addiction.
Yes.
Oh,
I
they
didn't
did?
know
Yes.
that. Right, there's not a ton of
November of
evidence, but-
2023.
Right?
There's limited evidence. There's limited evidence.
Tell your doctor.
I want there to be more of it, frankly, because actually I've seen benefit in more than a few, I mean, probably 10 or so patients now. Because of the guideline, I'm capable of doing it, because it used to be very taboo to give people like
Yeah.
stimulants for stimulants, right? But again, it does make sense from like a harm reduction standpoint that clearly something that's like used for ADHD, right, is gonna be less harmful than meth.
Yeah.
Obviously less is more pure, what's in it at least. But yeah, there's some evidence that it helps people with like cutting down their use or their cravings. It's mixed, it's not like it's like a bulletproof thing, that's for sure. But like I have patients, if they don't do well on Wellbutrin, because like I said, you want to mitigate, you want to improve some of the depression and the lack of energy from a dopamine depleted state. If they get benefit from methylphenidate, like I will, I mean, that's a good thing. So and they don't have to taper off it, you can stop it, yeah.
Just like
So,
Adderall.
one last
Yes,
question
long
is,
acting though, long acting ones.
maybe we can do a collaborative study with UCSF and UCSD.
That would be,
There,
we need to, we need to,
Because this has been
yeah.
very helpful to just listen to her talk,
Are
right?
you working with Monica? Are you gonna go work with Monica?
I am in work with Monica Gandhi, she actually is the person I interviewed with, yeah.
Alright, so.
Do you know her?
Well, I don't
Everybody knows.
Wow. I'm like the dumbest one then, because like I actually didn't know much about her till like like I applied the job. She reached out to me.
I think
Yeah.
it's great, but I do think from having surveyed the scene.
Yeah.
And from having been in this business for as long as I've been in, I do, and I'm saying this to all of you guys. We need your pressure for some rational approach to a massive societal problem.
Yes.
This is not subtle.
No.
The signal is like Mount Everest.
Right.
Okay, but having surveyed the scene so far, I think you would be very wise to involve pulmonary because of the pulmonary effects associated with smoking meth, and cardiology because they're being pushed given the cardiac side effects.
Yeah.
Because what I have seen, I am disturbed by the fact that the signal has been so big that I have not seen an adequate response from either infectious diseases or NIDA.
Yeah.
Okay?
Get your
tired of looking
contacts
at NIDA
from
graphs
this
where
desert
they're
for
gonna fund
cardiology.
Looking for the magic addiction center in a mouse brain. Right? I'm really tired of that.
Yeah,
I've
what's-
seen it for 30 years. And I'm sick of it. I actually started out neuroscience, I'm going back to neuroscience, I'm associated with the Stanford lab. And so I think that, either a privately funded, either an effort to get, if you get a privately funded initiative that just gives you preliminary data, right? And then, people are, well, why the hell is National doing this? I mean, it starts to move. And I think we need a rational approach to neurotransmitter system signals. As Dr. Gopal has said, I have 2 children with ADD. I live in North County. And I want you to know that the medical profession is putting long-acting amphetamines in the water. Okay, for
Really?
adolescents. Yes, because everybody's got ADD.
Yeah.
I mean, the society, we have to deal with certain society ramifications, right? And at the moment, you know, everybody's working stuff out. But for NIDA and other people to say that we're not going to try this category of drug when pediatricians are handing it out
Right,
wholesale
doesn't even make any sense.
is absolutely bizarre.
It's bonkers, right? Like-
So then I think that what we, I don't understand why we're not using the combination of CBD for sleep. Why we're not
Exactly.
using long
I do that all the time.
I had no idea, like, before COVID, when I was dealing with this, I started going to, I had a kid in New York City, so I'd go back and forth. And I made, you know, there's people who've been studying medicinal grade CBD that is manufactured for 15 years.
Yeah.
Right, so they exist inside the profession. We have amphetamines have been used since the 60s. Before that, I mean, they used it in the war, the bad background.
Oh, really? Oh, right, yeah.
We have, in medicine, when you have experience of a drug for 15 years, you know just about everything that you do, right? So we have a lot of experience with this, and I'm not saying we should just do. What I'm saying is that where are the clinical trials?
Yes, we need
Head-to-head,
more.
This thing.
We
with
need,
this
we need
thing,
all of
with this
those,
thing,
yes.
And I've never.
Maybe we'll do it
seen
at
anything like
SF too.
I think we just need a feasibility study.
So if
10
you
patients.
guys, not even.
You could, we could even
No,
use my own
we-
clinic's data, you know, we should just be looking at that.
What Dr. Gopal is telling us is that you can do a retrospective
Yeah,
on
Chart
some of the
study.
notes for the
Yeah.
Vivitrol.
yeah.
Right, and then.
They're gonna publish that, is what, who's the pharmacist? This is like hundreds of patients.
Lucas?
Lucas, right? He said, well, yeah, we got like hundreds or something.
Yeah, we have hundreds of patients on.
Right.
Someone
and
to
then
do
I
a
thought the plan was to-
Yes,
Yeah, they're
We
gonna
can-
publish
We
that.
can do it, yeah, but you should, but what I would say from the community standpoint, and for all of us, because we're all part of the community, is that there's something very wrong here. And I think if you guys start to move and say, you know, we want to sit down in a considered way and maybe fund a preliminary trial, or, as you point out, the pressure initially.
What, is it the
Didn't
planning
come from
council?
the internal medical community, it came.
Right,
from-
but a lot of these people have been on the planning council, like the organizations that decide where the money goes, once it goes from federal.
But
Wherever.
what the hell?
So what are the conversations like? Do they talk about substance abuse, mental health even? To get more money where it's, those are
You're
needed.
talking about the
Yes.
Ryan White money? No.
Yeah, yeah.
It's pretty restricted as to where it can be spent.
Uh-huh.
And that's one of the conversations I had with Scott Peters for RCDC for AWOC is we don't really need that treatment focused money. We need all the support dollars for the other things that are behind the scenes, like addiction, like transportation, like food, like health. Because now we have, there's nobody in this state that doesn't have access to some form of medical care that is supported, so you don't need Ryan White funding. But the law says 75% of that money has to go to direct care.
Why isn't direct care of substance abuse?
It's
HIV care.
It's HIV direct care.
You know, I have a question for
Very
Evan.
specific.
You know, Evan's in the trenches, he's in the.
he's in the trenches, yes.
And, you know, is there anything that is coming down the pike with in the way of cognitive performance or any of these things that you can foresee in the future? Because I think that meth is probably one of the hardest addictions to treat, isn't it?
Extremely hard, yeah. I have many patients who, meth primarily revolve, you know, they'll be with us and, you know, I have one coming in this afternoon that's probably the 5th time I've seen him in 4 months. So yeah, it's very challenging.
And like even at the rehab that he works at, which is pretty well, you know, it's like it's a nice place. They're not able to get Vivitrol for the patients because of insurance. For most of them.
I order often, but the delayed insurance.
It's killing the like patients, that's for sure.
Yeah,
The insurance restrictions.
Private practice,
Yeah.
that's been the biggest.
Yes.
obstacle. I would have given
Exactly.
a lot more.
Yeah.
But somehow Lucas, I think he's the one that really works that out.
It's because Medicaid, fortunately, Medi-Cal decided to cover like Vivitrol and all these drugs options that are available even for opioid use disorder. But the irony is this, it doesn't even matter if your insurance covers it. Insurance covers the drug. They have to cover the clinic where it's given to. So like if your clinic doesn't contract with Medi-Cal, you still can't get it. This is like such a dumb like setup for people to fail, basically.
Okay, that could be
Yeah.
a loophole because, if you're saying that 50% of your, the HCV clients are
Yeah.
tested positive for subcomputer.
Yeah.
The planning council can in fact sit there, if they're positive, they can sit there and support the mental health and subcomputer portion of it. They can't do the drugs, that would have to be through ADAP or some other program, but they can actually support that. But you'd have to have somebody sit there, go to them and propose to sit there and.
I mean, I think so. The Owen Clinic at least is, because most of the patients